From Robert Wood Johnson University Hospital, this is Medically Necessary.
Welcome to Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff. I'm Chris Hoenig, joined as always by Dr. James Salwitz. Dr. Salwitz, another beautiful day in the medical neighborhood.
Absolutely, Chris. So in the snow, it looks like it is continuing to melt, so I'm happy out there.
Ah, yes. Spring finally upon us, and so much promise, with the way COVID, the trajectory has changed in the past several weeks. In the hospital, we've seen our numbers decline, finally below 50. First time we've had that since, mid-November. You look at hospitalizations across the state, they're as low as they've been in that same kind of time frame. Nationwide, things look like it's getting a little bit better finally.
Yeah, I think there is really hope, but I think people are kind of enthusiastic. They literally see a light, at the tunnel, and so we'll get through this. But I think, as our president has said, yes, it's good, but wear a mask, be safe, and we still have a lot of work to do.
I cannot lose sight of that. Social distancing, mask wearing, hand washing, all still so important as we continue to move forward, as we continue to get more and more people vaccinated. It's going to be key to keep those numbers from rising again. And we would be remiss if we did not recognize the incredible leaders we have had here at RWJUH throughout this pandemic over the past year and going well beyond, before this pandemic started. The leader, the director of our infection prevention team, Pat Lafaro, joining us right now. Pat, this has got to be a special moment for you because the end of this second surge is marking the end of your professional career.
Yes, it is. Well, my professional career here in New Brunswick, hopefully I'll do still a little side work. But as far as hospital goes, it's the close of my era. I'm one of the original infection preventionists going back to the early 70s. So
you've been doing this for like 25, 26 years, right?
37 years.
37 years in infection prevention. Wow. So but to your point, your specialty has been built in this time.
I don't think infection prevention has ever been as important as it has been through COVID.
Absolutely.
I came to New Brunswick when Ebola was just hitting, and I'm leaving with coronavirus, but this really has been probably the greatest challenge of my entire career, or any infection preventionist's career. I think it has taxed all of us beyond belief as far as our resources and time, and just the challenges of trying to keep up with the ever-changing protocols. Sometimes several times a week, PPE would change, or guidance documents would change. So it really has been, an incredible challenge, an incredible journey. I think hopefully we are on the better side of it. And as you mentioned, I think the vaccination is the key to helping us stay safe from COVID. And again, all of our masking and social distancing. As we were coming out of this, for now, it's so important that people just don't forget that. It's very easy to fall back on being more comfortable, but we still, at this point, have a few months at least really still being very careful.
So looking at your specialty, infection prevention, particularly in the hospital setting, which really is has been evolving specialty over the last several decades during your career, literally. It was not a surprise to people in your specialty in the biggest sense that a pandemic happened. I mean, this kind of thing had been anticipated in literature by Tony Fauci himself, for years, that this kind of thing could happen. Even the model of it coming out of Asia, in discuss. So that wasn't, at the simplest level, a surprise. But looking at your specialty, what do you think your specialty anticipated? And how do you think your specialty was surprised and learned and grew through this event?
I think that it came so fast. Once it hit the first few cases, it was very rapid onset. And I think the shocking thing and scary part of it in the very beginning last year was how deadly. I mean, people literally coding in the ED, one after the other after the other. It's nothing that in my wildest dreams I would have imagined sitting and hearing over the overhead code blue, you know, sometimes 10 times a day or more in the emergency department. How that group of people have lived through this is really incredible. I just can't even imagine having to be, I work hard, but the staff that are in the trenches, they work a lot harder, and certainly emotionally incredibly draining for all of them. I would never have imagined to hear the code blues that we heard during the coronavirus in March and April. I think at least the second go around was very different. You know, our ICUs are not nearly as crowded, and most of our patients seem to be the medical patients, who again aren't even staying usually 5 or 6 days versus weeks. So I think the scope of it, the deadliness of it in the first was just beyond anything I could ever imagine.
Fascinating. You know, so I would say, and this is obvious to anyone that had the pleasure of working with you during this event, that your leadership was one of the things that made it easier, for lack of a better word, for those people in the emergency rooms and on the floors, you know, knowing that people were trying to, you were there, that other people, you know, in your kind of position were there, were trying to anticipate these changes, we're trying to give people the tools and the information as quickly as possible. You know, you made it, your sort of leadership made it possible to get through this sort of an event.
Well, thank you. But I have help. I have a great team. I had Dr. Baraclough, all of my staff who worked tirelessly 24/7 with me. And certainly, you know, it's just a team effort to try to keep everything going.
And Chris, we also have with us this morning, you know, Michele Pedrani, who will be following Pat in his role, you know, as the director of infection prevention. So, congratulations.
Thank you.
You know, so I mean, you also worked very hard this last year, so you're right there. So, you know, you've learned the lessons that we all of us learned, and you've given that leadership. So, you know, we're excited to see you stepping into this role and moving forward. So it's an exciting time going forward, and hopefully you'll get at least a few month break before the next major crisis.
We shall see.
Well, but I think that alludes to my next question, and it's kind of a question for the two of you. How do we look at the world going forward? So, you know, tomorrow they give the first shot of the Johnson & Johnson vaccine. The virus is magically gone sometime, whenever that is, being extreme. But so far we've dealt with this. How do we look at the world differently going forward? I mean, what are the permanent lessons here? You know, that we as healthcare providers to the individual patient and the community should have learned from this and should carry forward.
Well, I can honestly say the lack of supplies, the supply issue is definitely something that I was not anticipating as much, you know, and learning how to conserve and be creative with what we had, you know, anticipating that, you know, the likelihood could happen where you would run out, and what would you do then? So we're constantly thinking about options, and moving forward, we need to be mindful of these things because we don't know when the next one will come.
Yeah, I think really being on top of your supplies is key, because we thought about it during Ebola. Ebola kind of went away, and then nobody really paid much attention to having, you know, good PPE supplies, or supplies that were still in date and not rubber bands that are breaking because they've got dry rot and stuff. So I think that's a key thing. I think for people in general, look, there's no flu. We've had 4
Amazing.
cases.
There's no flu.
4 cases that have been admitted, one of those a pediatric, in the entire flu season, and we're now at the end of February. But all the practices we're doing to keep safe for coronavirus, hand hygiene, disinfecting of everybody's washing down their grocery cart before they push it. You know, people are disinfecting their hands constantly. We're masking. I don't really want to stay with masking, but the hand hygiene and the environmental cleaning are things that we should all realize how key they are to everybody's safety for any type of organism, bacterial or virus, and keeping your hands away from your eyes.
Yes. I think as a society too, the vulnerability of it, it shows how easy something, healthy people can be affected. So it's an eye opener for sure for us, and what to expect. I think as a profession, people tease us for the hand hygiene. When they see us, they're washing our hands and we're the hand hygiene police. But now I think they have a little healthier respect for us because they know it's a lot more than just that, but it was a major component and it's talked about every day.
So Michele, you've been with us in New Brunswick for about 25 years, part of the IP team for about 10 years. Pat, you were at Somerset for 26 years before we merged back here in New Brunswick, since that merger for the last 6 years. You both have had this perspective of the experience when we were more independent hospitals. How has being part of a system, Pat, I know you've been the co-leader for the system infection prevention team. What advantages of having a larger system behind you has that provided? You've talked about the supplies and being kind of surprised by how much of a struggle supplies would be. What advantages has being part of a larger system really provided during this time?
Well, I think the advantage is the size of the system, that if one hospital had more supplies, they were able to share or move things around. I think your buying power is better, maybe a little bit more political clout to get things. I think those are probably the advantages. I mean, there are times that we didn't have things that one of the other hospitals, Somerset would send something, or we would send some, equipment over to other hospitals if we had it. Most people weren't aware of that. So if we had an excess of some N95s and one of the sister hospitals was out, we would shift and share our stuff.
And just generally sharing information within the system. Different regions impacted a little bit differently at different times during this whole thing. So being able to reach out to another hospital and see what they were experiencing and kind of communicate what might be coming next for us was very helpful.
That's an important point because it shows that one of the lessons or the things that we need to do between crises and the lull of crises, since we're in the medical business, there's always going to be something out there, is to build systemness and those connections and those, because all those pieces are important. And the reverse of that, and Michele, you alluded to this, the vulnerability of certain individuals, our need to reach out to our communities and to build those connections, because we do know that this virus, hit, diverse communities, vulnerable communities harder, than other communities. And, as, Barry Ostrowski is fond of saying, we're not going to succeed as a system until our entire communities are healthy, period. And that shows, again, the need to make these links, and to reach out. And it's the opportunity is there, but also the obligation.
Yeah, and I think it's Michele alluded, the communications. It's really one of the really good things about it is we have a monthly infectious disease, infection prevention leaders that meet monthly, even through a lot of COVID. We only canceled a handful of meetings. And that's it's a great exchange. It's very difficult getting a lot of IDs and a lot of IPs to agree on everything, but we can't make everybody happy. But it really is a great way to share a lot of information. There's a lot of intellectual capacity in that group, and not only including IDIP, but pharmacy and quality. So it really is a great group and a great learning experience. One thing I've learned in infection prevention, you never stop learning. Every day, always amazes me. There's always something more to learn.
So Pat,
I'll do still when I retire. I'll actually have time to read it.
Well, that leads my next question, Pat. So you're stepping down from this position, and so what is your plan?
Well, first it's going to be a few months of decompressing and having fun, and then I have to decide what to do. Well, I do consulting and ambulatory, so I may take on more clients. I dropped a lot of them actually when I came to New Brunswick because it was too time consuming in New Brunswick to have private clients. So I'll probably do some of that and love to travel. I have a daughter moving to Tokyo, so.
Oh, geez.
Yeah. So, and hopefully grandchildren, maybe. So, lots of fun. I'll learn how to play golf. I have a piano sitting in my living room, so maybe I'll actually take lessons.
Outstanding. So if you were to tell future leaders at Robert Wood, or just to really put you on the corner, Michele, a lesson that you've learned as a leader at Robert Wood going forward, what would that be?
Just communication is key during this whole process. I mean, it was a beautiful thing to be able to coordinate between, EBS, cleaning of the rooms during the pandemic, to environment of care rounds, which included, facilities, pointing out maybe our weaknesses, things that needed to be worked on. Just, you can't survive in a silo. You really can't, and be able to function and thrive and come out of this okay. It really is a coordinated effort. So if anything, working together, communicating, were key.
And along those lines, that level of collaboration, we've talked about some of the ways that public behavior may change post-pandemic. Aside from the collaboration, what do you think are going to be some of the changes that we see at a hospital level in terms of infection prevention or beyond that as a result of this pandemic?
A lot of private rooms.
Yeah, absolutely.
Maybe people will take us more seriously when we talk about things,
Right.
And it's not going to be, here they come again,
That's right.
see you more as a part of a team, not always there for a problem.
That's a good lesson, so. Well, Pat, thank you again for all your work, over the years, but particularly through the penultimate crisis of your career in this last year. We, obviously wish you luck, and going forward. And Michele, I look forward to working with you, in the years to come. And anything, of course, we can do to support you. You're always welcome back on the podcast.
Thank you very much.
And thank you for what you're doing and what you're taking on. So thanks both of you.
Great. It's been great working with you both.
Pat Lafaro and Michele Pedrani, the outgoing and incoming directors of infection prevention here at Robert Wood Johnson University Hospital, New Brunswick. Speaking of past and future, we now have a museum at Robert Wood Johnson University Hospital. We'll be sitting down with the curator of our Anesthesia Museum, Dr. Enrique Pantine, coming up. We'll be right back.
What makes a hospital an academic medical center? Being one of only 7 nursing programs in the world to receive the Magnet designation 5 times. A nationally recognized children's hospital with specialties including regional perinatal care. A neuroscience team closing in on the nation's 3rd largest killer. A partnership with the Rutgers Cancer Institute of New Jersey. Cardiac medicine, where hope is transplanted along with hearts. A comprehensive liver disease and digestive treatment center. A bariatric program with long-term results. And a level 1 trauma center that's above it all. Research, education, patient care, everything you'd expect from New Jersey's premier academic medical center. Robert Wood Johnson University Hospital. Let's be healthy together.
Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff.
Welcome back to Medically Necessary. Chris Hoenig here, as always, with Dr. Jim Salwitz. And, Dr. Salwitz, the last week or so, all of a sudden, it just feels different out there, right? I mean, all of a sudden, winter took a step back for a few days. The snow started to melt off. Then J&J presents to the FDA. And all of a sudden, it feels like spring and truly in that sense of rebirth. Like there is a light coming, like things are getting better.
Yeah, I think you're 100% right. There's this microscopic feeling that there may be hope, we get beyond it. How pathetically sad this is that, we're just reaching and hoping. Is I looked out my window this morning at home and I saw the edge of my roof. I mean, like, literally, this is what I saw, not covered in snow. And I go, I can see the edge of my roof. There's hope. So, I mean, I do think that, as the snow melts, as the sun comes out, as people get vaccinated, as we spin out of this thing, I do think we're looking forward to some really exciting and positive things going forward here. And the reality is, Chris, there are a lot of really outstanding things that are happening here, and in the system and in the state, and we have a lot of work to do. A lot of it's positive. So I'm kind of looking forward to this year and the things that are going to happen.
And of course, as we look forward, in the words of George Santayana, those who cannot remember the past are condemned to repeat it. And so maybe a little history lesson is in order. And with that, I'd like to welcome Dr. Enrique Pantine, a member of our anesthesiology team here at RWJUH and Rutgers Robert Wood Johnson Medical School, and the curator of the Anesthesia Museum. So Dr. Pantine, thank you for joining us, and thank you for your incredible collection that you have.
Well, I appreciate first the invitation. It's really nice to be able to talk about something that I like a fair amount, if you might guess by what you see. And so Chris, thank you, and Jim as well for giving this opportunity. Well, I've been in our system now since 1996, first as a intern and then a resident, and then I went away, did my fellowship. But before that, I had also a life in Venezuela, where I actually am from. My mom from Michigan, and my dad from Venezuela. So I did medical school over there and practiced for like 3.5 years. And at my practice, I saw how what we were doing in anesthesiology in particular, but also in the medical field in general, how things were evolving really, really fast. And I think there was a time for us, a little less young practitioners, that medicine was moving faster on some areas, especially in equipment and technology. We went from the rotary phone to the cell phones, and the same thing, the media of communication. The same thing happened in my specialty, in anesthesiology in particular. Technology took over, and as I saw technology coming in, I also saw a lot of the old stuff disappearing. And also I saw a lot of those stuff actually just put in a corner and sometimes in a box and sometimes in the trash. And I felt like a little, I'm not going to say hurt, but I felt a little like, I don't know, nostalgic or hurt or I don't know exactly what it was, but it didn't feel right to have these things actually disappear from our view and kind of in a way forgotten, and it's very easy to forget, our predecessors and the people that actually had inspired directly or indirectly for what they did or how they, set up the land. So that's how it started, sparked the curiosity for me to start this little collection that became a little bit bigger.
It's fascinating. I think a point you make indirectly is that, we build on what has come before. None of this is just shipped to us from Amazon in reality. The reality is that it had to be created one step at a time. And it's been a long, very challenging journey. And it's exciting to be part of that. And I think it's important to recognize that because it helps you understand your place and what is possible, as we go forward. So I applaud, your decision to make sure we keep that history so that we understand, where we can go as much as where we've come from.
Yeah. And that's the funny thing about this is, you start collecting and you think you will get to the bottom or to the end of, let's say, a series or some idea in general. And then you discover there is another layer under and then another layer under. And then what you thought was, one or two, discoverers or the fathers of some area is like, 100 people more under them, and before them. And it's just quite amazing, though, to see how easy, besides forgetting, but also not realizing how all what we are now is thousands and thousands of people, and even in the smallest area, that actually contribute one way or another. And that's something that's been interesting and fascinating to me to discover, that I will never be able to complete a collection. I will probably be able to complete some areas that are very, very small, and also how big the world is, because we see many things as like, American or from whatever other country we know a little bit, but it's the whole world, just from what I have very minimal things or nothing really from China, for example, so I know nothing about how things started over there, except what the books tell us. And that gives a little more understanding of how deep, the history really goes into the details, and how many people, came with an idea almost at the same time at different places. And the one that talked first is the one that got the credit,
Absolutely. So, and I do think it also should encourage us as clinicians, as academic clinicians, as scientists, to reach out and make those connections. It's one thing to really study hard and understand the thing that's right in front of you, but also to understand that in the world, there are other people, as you say, that are interested in many of these problems, and we learn from each other. And that's where maybe one of the greatest strengths that we can have.
Yes, and with that, it's interesting because at least we think, or I think, I used to think, like the medical doctors in anesthesiology, and then as I continue to move forward, you discover other people that had nothing to do with medicine itself, just engineers. They got curious about it, and there are a few of these that I have in my collection in terms of heroes or forefathers, even though there are many. And there is one or a couple of these in particular, that you never knew about it. It's a PhD gentleman called Richard von Forger, who was born in 1872 and he died in 1960. But he invented so many machines or elements in tools for anesthesia that he was everywhere. He had laryngoscopes, he had different tubes, he had intubation sets for the military. He had anesthesia machines for the military. We actually have at least one machine here that is from the 1950s, actually for military use, that I was lucky enough to get from a person who was cleaning a basement of a school, and there were a bunch of boxes in that school, and he actually said, "What are you going to do with these boxes?" And they said, "We're going to throw them away." So I took him to his house, and when he opened, there were old anesthesia equipment there, among other things. Yeah. So then he puts it for sale, and I got a hold of them, and I actually acquire it, and it's like out of the box, pristine, new machine from 1950s for military use with all the components, which is a beauty, never used, So otherwise, we would end up in the garbage, which is again the sad part, but the interesting part is gentlemen like non-physician engineers actually did so much for this specialty.
What other things, or what other kind of things are in the collection?
Yeah, so my initial curiosity was preserving stuff. So when I started in Venezuela, I found medications that were no longer in use. Like they used to use before propofol, that everyone knows about propofol, as a sleeping agent and for colonoscopies. We used to use thiopental a lot. And I got a hold of a 5-gram vial. And just to give an idea, the normal dose is, like a tenth of that or in terms of a dosing for a patient. So they used to have this multi-dose vial that you can actually draw all the practitioners and then use for your particular patient. And this is, we're talking about now the 80s and 70s, so not too long ago. And then, of course, propofol came into American market in 1989. But it took 3 years from England, where it was discovered, to America.
Because Michael Jackson brought him over, right?
Yes.
I thought so.
The Michael Jackson drug, I guess. And the interesting thing about that, because this is, again, going into details here, the doctor who discovered propofol was a veterinary doctor that started working for a company that used to be called ICI. It was an Imperial Chemical Industries in England. And there were thousands of molecules that were not studied. So when he got there, he started looking at different molecules, looking with his background in veterinary medicine or something to put the animals to sleep as initial concept. And he screened all these molecules that they have, and he found a few that were interesting with anesthetic properties. And then in 1973, he discovered, this drug has been in the shelf for who knows how many years, and put it to different studies. It took 13 years to come to market, just to show how someone that was curious enough to look into what was available in the library of drugs in a chemical company found a medication that ended up being revolutionized medicine and anesthesia in general, in particular, I guess. Other things that I have in the collection, start from as early as anesthesia was discovered. And we talk about the discovery of anesthesia is something that happened at a particular date. And I think the main discovery was the use of a drug that at that time was ether, as the drug that could be used to actually provide unawareness and amnesia and immobility in a patient that was submitted to surgery. And that actually occurred in 1846. But before that, ether already been discovered in 1275 and then synthesized and by in 1540. So really,
So ether was available in 1275.
Discovered in 1275 and synthesized in 1540. That's how much time it took to realize that ether was a drug that can actually put someone to sleep until finding someone made a connection. It took,
I shouldn't be too frustrated that J&J got the viral approved today, but we won't have the virus till next week.
No, give them another week.
Give them another 700 years.
Yeah, at least. yeah. So it's funny because a drug is available. No one actually made the connection. They were, in the early 1800s, in late 1700s, ether parties and nitrous parties just to smell, and people will pass out, and they just use it for fun until a physician, it was actually a dentist in 1846, Dr. Morton, who did the demonstration, and this was interesting too because he decided to demonstrate it. It had to convince a very famous surgeon and Mass General at that time. It was Dr. Warren Collins actually to demonstrate this in public. And when he did, it's like October 16, 1846, it became to, fame. The surgeon said, well, this is no humbug. It actually works. And from there on, just, it's all history, I guess.
Fascinating. Really
one
fascinating.
One of the things I found really interesting about this collection, one of those facts that I learned, Dr. Crawford Long, right? One of the fathers of anesthesia. Doctor's Day, National Doctor's Day, celebrated March 30th because of Dr. Crawford Long.
Yeah, he is really one of my heroes because this town surgeon, a medical practitioner, he did everything. He not only did, general medicine, he did, pediatrics, he did, GYN, obstetrics, everything. So it's Crawford Long was actually a medical student at the University of Pennsylvania. And then he moved to a town called Jefferson in Georgia, where he had his practice of medicine. His brother was also a physician. He also had like a drugstore on those days. And he made the connection before Dr. Morton. So he made the connection in 1842, even before that, and decided to use it in a patient who was extremely nervous. He had a neck mass. And the patient had come 2 times to have it excised, and then he went away. He didn't want to have surgery. And then he told him, let's try this, drug that I have that I think is going to help you and it'll make you, not suffer with the surgery. So in March 30th, 1842, Dr. Crawford Long actually excised, administered ether to this patient, and his name was James Venable, the first actually patient documented to receive a general anesthetic, and he excised a mass. And when he finished, the patient woke up and he said, well, when are you going to do this? We're done. The mass is out. And that's how everything really started out. The unfortunate thing for him is he never actually publicized this. He did other cases, and it took a while. And in my collection, I have a book that his daughter wrote in 1928 about his father, just showing all the tribulations that a small town surgeon physician will go through, and kind of demonstrating that he was the first physician who actually used ether as a general anesthetic. So he's actually really the true father, although an unknown father, and Dr. Morton is the known father in a way.
And I don't hear a lot of IRB approvals in any of this.
No. Great times, James.
Run out and back and take a shot.
Yes.
Wow. So these things are on display. And when can people see those?
Yes, they're available. We have them on display in one of our halls. They have a fair amount of traffic in front of the same day surgical suite area. And they're going to be there at least for 6 months. I hope longer. Hopefully we'll be able to move things along a little bit and keep people interested in it. They were in display before, though, in the anesthesia department in the CAP building. But there's an area that only has traffic from us and candidates when they came for interview, when we used to have candidates visit the department. So they were located in an office, in my clinical office. Actually, I have many of the items, and I have another office with some of the anesthesia machines as they take some space. But Dr. Lewis, our chair, actually, gave me the space to do this. So they've been, on display, but in a much less public, area. And that's a very nice thing that we have the opportunity to put them in full display. It's also worth mentioning that, like everything else in medicine, I have not done this by myself. I've over the years have collaborators. I think it's a list of 12 people that actually, doesn't matter how small the piece. I have like one colleague of mine that gave me a little tiny, stethoscope adapter, but it was it's an antique thing. And he's part of the donators to the museum. And they have another colleague from California. When he retired, he donated a lot of his endotracheal tubes and other devices that he had. So I have, people that contribute significantly to the museum just for the good of their heart. And with that, I have, and it probably isn't displayed, one of the oldest masks that we have. It's from 1874. And it was done by a surgeon, Dr. Alice, who actually made many surgical instruments as well. This was a mask to administer ether. And this mask actually was purchased by the wife of one of our surgeons, Theodore Eisenstadt, which is a colorectal surgeon in our hospital. And she bought this for him as a gift in an antiques house in 1982. And then he, a year or two ago, donated to the museum. So, there are several valuable pieces in the museum, even rare pieces that are, very difficult to find.
Very, very exciting. Well, Enrique, thank you very much for doing this. Thank you for the enthusiasm and also taking the time to join us here. It's really very interesting. And I think it's consistent with the strength of your department, of the academic mission, and I just think the appreciation of everything that is changing and happening here. So again, thank you so much.
Well, I appreciate, Robert Wood, is and has been my house since I've been here. So it's many, many years. And it's good to, be even more integrated in an aspect that is so important to me and so representative of us as physicians and all the tribulations that we've gone through. So I appreciate the opportunity again.
As we advance medicine, never losing sight of the past. Dr. Enrique Pentin, thank you so much for joining us.
Oh, thank you very much, both of you.
As always, Medically Necessary is available on all of your favorite podcast platforms. You can subscribe now on Apple Podcasts, Google Podcasts, Spotify. We have the playlist on YouTube, and we are available through the Robert Wood Johnson University Hospital Medical Staff Portal. For Dr. Jim Salwitz.
For Chris Hoenig.
Thank you for listening.
Medically Necessary, brought to you by the Robert Wood Johnson University Hospital Foundation.